Attention please, dear ladies and gentlemen, we are about to begin the next session, so we kindly request all of you all to be back in the main hall. To begin with, I would like to invite Dr. Bo Remini to give a lecture on what is new in rheumatic fever. We'd like to invite Dr. Duminda Samarasinghe and Dr. K. Sudaresan to chair the session.
Good morning, ladies and gentlemen. Welcome to another very interesting session on rheumatic fever. It's all about what is new in rheumatic fever. It's my great pleasure in introducing Bo Remini from Australia. Actually, we were trained together, and in 2009, after training, she disappeared into the bush in Australia and started treating indigenous people with rheumatic fever, and has reappeared this year, winning the award of Australian of the Year. So she was awarded for the work that she has done for rheumatic fever patients in Australia. So it's over to you, Bo.
Thank you, Duminda, for that very kind introduction, and also like to thank the organizing committee, not just for inviting me to come to Colombo in Sri Lanka, but also for putting rheumatic heart disease on the agenda at this meeting. We have heard so much over the last day or two about diseases of the rich, ischemic heart disease, and we mustn't forget that we still have rheumatic heart disease in Sri Lanka and in the world, and it's a nice opportunity to refocus on the diseases of the poor. So, as I said, rheumatic fever and rheumatic heart disease are 100% preventable illnesses. Yet, globally, there are some 33 million people worldwide, mainly socio-economically disadvantaged populations, who suffer from this disease. And my talk today is on what is new in rheumatic heart disease and rheumatic fever. And this graph is very new, published in 2017 in the New England Journal of Medicine, showing that we got new, up-to-date figures on the prevalence of rheumatic heart disease globally. Now, we not only have up-to-date prevalence globally, but we now also have more specific data region by region. And this map, which is available on the interactive website on rhdAction.org, when you go on this website, you can see local prevalence of rheumatic heart disease. Based on these estimates, there are some 300,000 people in Sri Lanka living with rheumatic heart disease. And the overall burden of rheumatic heart disease in Sri Lanka has actually increased by close to 30% over the last 10 years. However, if we look at age-standardized prevalence of rheumatic heart disease in Sri Lanka, it's very refreshing to find that Sri Lanka is in the green color, which showing that the age-standardized prevalence of rheumatic heart disease has dropped over the last 10 years. More information around mortality. Approximately 128 people, female patients, die from rheumatic heart disease in Sri Lanka. And if you compare my home country, which is Australia, mortality is about 3 times as high, and the two countries' populations being very similar, both being around 22 to 24 million. So it just highlights that most people in the audience might not have realized, but we have got a big problem with rheumatic heart disease in Australia, and it mainly affects our indigenous populations, the Aboriginal people who live in very remote and rural environments. So what is new in rheumatic heart disease? I could just show you this slide, which highlights some of the amazing work that's being done globally. So if you look at the light blue on the bottom, we have got a lot of research happening globally to come up with better diagnostic tests for rheumatic fever. At the moment, we just have the streptococcal titers, which are not specific for rheumatic fever, but it shows that you had a previous exposure to the strep germ. We have a lot of work being done around vaccines, also research being done in Australia and overseas to come up with a better penicillin product, so a better method of delivering penicillin that does not require monthly painful injections. There's also a lot of work on skin and throat infections, echo screening, global burden of data, but also on global advocacy. Now today I won't have an opportunity to go through all of these little circles with you, but this chart is just purely to highlight how much work there is being done across the globe to try to address rheumatic heart disease globally. This is just a short video to set the scene for you in Australia. So it is a very tragic condition of poor people across the globe that starts from a simple throat infection yet leads to premature death or open heart surgery, and often both. So let's go back to what is new in rheumatic heart disease and see what kind of initiatives there have been globally to try to address this condition. So we all know that rheumatic fever starts from a group A streptococcal pharyngitis. But what is new is there's increasing evidence coming from Australia, New Zealand, and from the Pacific that impetigo, streptococcal skin infections, also can contribute to the development of rheumatic fever. So in some parts of the world, to prevent rheumatic fever, it is also important not just to address sore throats, but also skin sores. In a population that I serve, on any given day, up to 45% of all children will have skin sores, yet the burden of pharyngitis is extremely rare. So this is a new piece of evidence, a number of articles there to suggest that this is a really important part of the pathogenesis. So the next question is, if rheumatic fever and rheumatic heart disease is preventable, why haven't we got a vaccine to prevent the infection itself? The vaccine development started in the 1920s, and it's been a slow and arduous process. But right now, there's a number of people around the world who are working on accelerated development of a group A streptococcal vaccine, and it is possible that within the next 3 to 5 years, we will have a safe vaccine on the market. The challenges are, as you can see, there's lots of different types of group A streptococcus, and to ensure that the vaccine that is developed is actually effective in preventing acute rheumatic fever. Those are the 4 vaccine candidates. Some are targeted towards the more conservative side of the M protein of the streptococcal germ, and others the more variable parts. In New Zealand, there's a government-funded project together with Australia to try to develop a roadmap for this vaccine and to make sure that it leads to a safe and rapid licensing of the product. In the meantime, while we're still waiting for the development of the vaccine, we need to take a step back. So what it is that we can do to prevent rheumatic fever. We know, and there's increasing evidence out there, that rheumatic fever is a disease of poverty, and social determinants are really important in causing rheumatic fever. So addressing overcrowding is really important, not just in your situation, but definitely in the Australian situation as well. This is a pretty typical two-bedroom house that normally accommodates about 20-25 people in our remote Indigenous communities. With regards to primary prevention, the best way of addressing sore throats is getting rapid treatment for throat and skin infections. It's easy to say on an individual level, but how do we implement this on a national or global stage? An analysis from South Africa demonstrated the most cost-effective approach to preventing rheumatic fever is treatment of all sore throats with penicillin. Different decision rules have been developed to try to differentiate a viral sore throat from a bacterial sore throat, and none of them are really sensitive or specific. So if in a given population rheumatic fever is a big issue, then the best way forward and the most cost-effective way forward is prescribing benzathine penicillin for all sore throats. Now, the picture on your left-hand side is the data from New Zealand, where they did not implement that, but they tried to do a more specific and targeted sore throat treatment, where every single child with a sore throat had a throat swab done, and if streptococcus was present, then they had oral penicillin prescribed. And what they were able to demonstrate, this school-based program, so instead of kids going to the GP or your medical officer, health workers going out to the school and asking children every day, have you got a sore throat? And if they did, they had a swab and then received penicillin. And there was only a modest decrease in the overall incidence of rheumatic fever using that approach. Okay, so once you had a sore throat untreated and you worry about a patient having rheumatic fever, how do you diagnose it? Well, in 2015, the revised Jones criteria were published in circulation. And while it's a complicated document, for those of you who have junior doctors or nurses working with you, there's a brand new app available on the website where you actually can download a diagnostic calculator. It's free of charge under RHD Australia, which helps your junior doctors diagnose rheumatic fever and rheumatic heart disease. So what is different about the 2015 Jones criteria? Well, firstly, it has become much more sensitive. So the biggest difference compared with the previous edition is there's two separate sets of criteria, one for high-risk populations and one for low-risk populations. For those who belong to high-risk populations, the criteria has become very sensitive with inclusion of polyarthralgia as a major criterion and monoarthralgia as a minor criterion. And some of you in the audience might be old enough to remember the original Jones criteria from the 1960s, and this new iteration is very similar to that first one. Because over time, as the incidence of rheumatic fever dropped in Europe and America, the revised editions of Jones criteria had become more and more specific and less sensitive as the prevalence of the disease dropped. So this edition has gone back to a previous version and allows for a higher sensitivity in high-risk population. In addition to the modifications of the joint symptoms, this edition also includes echocardiographic diagnosis of subclinical rheumatic heart disease, and also allows for the diagnosis of possible rheumatic fever. I'm sure your population is not dissimilar to my population, when sometimes children present quite late by the time they reach a general practitioner or a cardiologist. Sometimes weeks or even months have gone past. And retrospectively, it's not possible to diagnose rheumatic fever accurately if you didn't have your blood tests, your ECG, and echocardiography at the time of the suspected episode. So when incomplete information is available, The 2015 edition allows for a diagnosis of possible rheumatic fever and just treatment for 12 months rather than 5 to 10 years. So let's talk more about echo. So we know that echocardiographic diagnosis is much more sensitive than using the old-fashioned stethoscope. But at the same time, we want to be really sure that we are not over-diagnosing rheumatic heart disease and rheumatic fever, because if we do that, then it puts additional strain on our health services and on the families and the children who have to receive unnecessarily painful injection for many years. So the Jones criteria very clearly specify what is considered to be physiologic versus pathologic mitral regurgitation. So regurgitation, to be pathologic, it has to be seen for 2 views. For mitral regurgitation, it has to be at least 2 centimeters long as a jet length. But most importantly, one has to be able to demonstrate a pan-systolic or a pan-diastolic regurgitant jet on CW Doppler. So just like you would do for tricuspid valve regurgitation when you're measuring pulmonary hypertension. So this is a really important part. The reason why it's so important is because we know that any mitral regurgitation, just a little bit like a trivial, occurs in 30%, 20 to 30% of all school-aged children. So echo is so sensitive these days that 20% of all kids, healthy kids, with nothing wrong with them, will have a trivial amount of regurgitation. Now, we don't want to be diagnosing all those patients with rheumatic heart disease. That would be just not sensible, and hence the very, very strict cutoff values. The videos have stopped playing, but what you saw in the top part, the top video, which demonstrates, could we replay the videos? The top part demonstrates a pathologic regurgitation, and the bottom video demonstrates a physiologic regurgitation. So there's very subtle differences, and the cutoff is arbitrary, but it is important to follow some guidelines, especially when you're subjecting your patients to long-term penicillin. So moving on to secondary prevention. Unfortunately, the only thing we have available today is benzathine penicillin G intramuscular injections. Nothing has changed, but there's some amazing work being done in Australia in coming up with a better formulation that potentially longer lasting, like a depot injection that could potentially last for 12 months. We're probably still a few years away for having a product available, but just watch out for this. This is all happening. In the meantime, once someone has rheumatic heart disease, apart from penicillin injections, there's nothing else that modifies the illness. Some studies were done some 30, 40, or even 50 years ago looking at the benefit of corticosteroids. Unfortunately, those studies were done before echocardiography was available. And really, the results are inconclusive. There was no clear benefit of using corticosteroids, even in a setting of severe rheumatic heart disease. Saying that, I still use it in cases of severe rheumatic heart disease, but it's not a very evidence-based treatment. Certainly some work being done in Africa and in Australia to develop better immune markers for rheumatic heart disease and rheumatic fever, and hopefully develop some targeted therapy that could alter the natural outcome of acute rheumatic carditis. So, if we're left with nothing but penicillin, it sounds simple. All we need to do is deliver penicillin injections every 3 to 4 weeks for a minimum of 5 to 10 years to prevent the recurrence of rheumatic fever. This is best done through a registry-based program, an organized program to ensure that patients get the best possible outcome. But in reality, it seems to be much more challenging. Certainly in Africa and in some parts of India, and perhaps even in Sri Lanka, there's a fear of delivering penicillin injections because of a possible risk of anaphylaxis. And this has been very carefully studied in Africa. And what the African, specifically in Zambia, they found is providing education about the very low rate of anaphylactic reactions, providing training on how to treat anaphylaxis, removes the need for skin testing. Because allergic reaction occurs in about 3% of population, but anaphylactic reaction is very rare. And the skin testing itself can create an anaphylactic reaction. And a single skin testing does not give a definitive yes or no answer if anaphylaxis will develop in the future, because you could have a normal skin test now and in 12 months' time still develop the very, very rare anaphylactic reactions. So we no longer recommend skin testing unless there's clear evidence of previous reaction. So it is intramuscular penicillin that's better than oral penicillin, unquestionably. And we also know that if we wait for patients to present with rheumatic fever to us, we will miss majority of the patients. Certainly, globally, most patients who have rheumatic heart disease have never had a documented episode of rheumatic fever. And even if we look at Australia, 50% of our patients needing cardiac surgery have not had a documented episode of rheumatic fever. So the only way to detect rheumatic heart disease early in some populations is by going out and screening for rheumatic heart disease. The World Heart Federation criteria was developed to promote early detection for rheumatic heart disease. Very strict guidelines were set, and it's been demonstrated it's much more sensitive than auscultation if we're going to implement this on a population basis. And these are some international studies demonstrating when you go out and look for rheumatic heart disease, in certain countries, up to 2 to 4% of a population in children will have such problem. If someone is embarking on echocardiographic screening rather than auscultatory screening for rheumatic heart disease, it's very important to follow the strict WHF criteria to avoid overdiagnosis. To diagnose rheumatic heart disease on echo alone, so people who never had any history of rheumatic fever, purely if a child is having an echocardiogram for whatever reason, it's insufficient just to show regurgitation of the aortic or mitral valves. It must be combined with some structural or morphologic changes. So for acute rheumatic fever, if someone presents with a sore joint, it's enough to have pathologic regurgitation to meet the major criterion. But if someone comes to you completely asymptomatic for just, let's say, investigation or murmur, it's really important to demonstrate structural and functional changes of rheumatic heart disease before calling it definite rheumatic heart disease. And more information on this is available through the WHF website. And these are just some examples of morphologic features of rheumatic heart disease. So finally, tertiary prevention. What's new? Unfortunately, all the new oral anticoagulants are not licensed for atrial fibrillation in the setting of valvular heart disease. The good news is there's some randomized control trial happening right now in Africa. They're already through the second year of their recruitment of the patients to demonstrate the safety and efficacy of the newer anticoagulants in a setting of valvular heart disease and atrial fibrillation. The data from this study should be available within the next 1 to 2 years and potentially could replace warfarin in this setting. With regards to cardiac surgery, we know that mechanical valve replacement is very risky, especially in females, especially in resource pool settings, with very high complication rates, especially in the young. Mitral valve repair is a much better alternative. However, it does not last forever and often necessitates redo surgery. So I suppose what we learned and what we already knew is the prevention of rheumatic fever is better than cure, especially that there is no cure for rheumatic fever at this stage. And surgery is merely a palliative strategy. So whilst there's a lot of work happening already, the more work needs to be done so we can get rid of rheumatic heart disease together. And it is quite impressive to see the publications related to all the different aspects of rheumatic fever and rheumatic heart disease. Now, on a positive note, the most positive thing that happened in my lifetime was in May 2018. At the World Health Assembly in Geneva, there was a global resolution on rheumatic heart disease. What does that mean? That rheumatic heart disease has now finally, for the first time ever in history, has been prioritized as a global public health agenda. And as if you recall, in 2011, there was a global resolution on non-communicable diseases. Now the same thing has happened for rheumatic heart disease. This is going to give a lot of impetus for individual countries to get rid of rheumatic fever, but also globally to advocate for accelerated vaccine development and other important measures to address rheumatic heart disease. Thank you.
Thank you, sir. Next, we are moving on to a symposium. A symposium with a collection of multiple topics. We would like to invite Dr. Janaka Pathiraja and Dr. M.H.M. Sahi to co-chair the session.
So the next agenda in the sessions will be a mixed bag, a symposium, and the first topic will be on intervention in arrhythmias by Dr. Mervan Wijetunga. Please take over the podium, sir.
Good morning. It's my great honor to be back. As the years go by, it's indeed a privilege to share a few things you have learned along the way. So I'm here with a sense of gratitude to my teachers and also cherish the opportunity to interact with my peers and colleagues and friends. I was assigned to talk on interventions in arrhythmias, and that puzzled me, the topic. So I talked to the organization committee to give me some guidelines as to what I should be presenting, and I was given a broad mandate. So this is the way I prepared the talk. The intervention, the term, denotes an action taken to improve a medical disorder or prevent it from getting worse. And in electrophysiology terms, the intervention could be pharmacological, procedural, or surgical. More lately, we are also thinking of lifestyle modifications, particularly related to atrial fibrillation, weight loss, alcohol cessation, and so on. But for most of us, this interventional term means something procedural. So let me focus on that. Now, before talking about interventions, one has to make a diagnosis. And without a diagnosis, you can't intervene. And those of us who remember going to the Veda Mahatyas during childhood days at least what I recall is he takes my pulse and then he writes a concoction of herbs, which my mother boils in the kitchen, and I drink it kasaya. And that's based upon pulse. So the pulse theory existed for millennia before we did anything and everything. And indeed, it was not restricted to Ayurvedic nadi, but also in Chinese culture, or subsequently in medieval ages in the Middle East, as well as in the Greek and Roman and so on. And to the upper right, for example, now this pulse was used to intervene, and not only you take the pulse, not only make a diagnosis, but also a prognostic thing, and subsequently intervene. A good story comes from this upper right, where a medieval Persian philosopher and the physician, his Latin name was Avicenna, or his name was actually, I think, Abibuin, something like that, but Avicenna, he examines this young patient whose pulse flutters at times. So he's with his students and he checks the pulse, and then he feels, the patient complains, my heart flutters at times. And he checked the pulse, and what Avicenna does is, after checking his pulse, he talks like a series of districts in that area, 1, 2, 3, 4, 5, 6. At one point, the pulse flutters. Then he focuses on that district and gives some street names in that district. And at that point, a heart flutters again. So then he goes to the household names in that street and give a list of names. At one point, the heart flutters. The diagnosis is made, and he intervenes. He says, this man is in love with a girl in that household. So the intervention was done, hopefully, right? So the things evolved. So let me highlight a few things that came along the way for us to help diagnosis. And obviously there are many, many pioneers, but I just took a few of them. We can't forget Willem Einthoven in 1901, who developed this 600-pound machine called string galvanometer, where you put one leg in an electrolyte solution and one hand in an electrolyte solution, where you can create an ECG. Prior to that, Willem Einthoven, this was the ECG developed by Augustus Waller. He called the waves A, B, C, D. In fact, A would have represented the P wave, but the fidelity of his instrument was so poor, he could not pick up the P wave signal. But C represents QRS, and D is the ventricular depolarization. And what Einthoven did was he refined it. And I'm not going to details how he did it, but he named it PQRST based upon how they used to denote mathematical curves at that time. And to this, he was awarded the Nobel Prize in 1924. And this was a landmark in diagnosis. And years went by. Not until 1969, the next most important step was made in electrophysiology. This is Ben Sherlock from Oklahoma. He developed a way, which we consider today a very simple thing, but he developed a way how to put an electrode catheter to the heart and find where the His bundle is and put it on a piece of paper. This is the His electrogram. Because you might think it's simple, but without knowing that where the His bundle electrogram is, you cannot really know whether electricity going from top to the bottom or bottom to the top and where the circuitry occurs. So this was a huge landmark. And then people took up on that. So this is where the bundle of His now. It's sort of at the junction between atrium and ventricle, just below the AV node, and putting a catheter to detect that. So this was initially used not for any electrophysiology study, but to assist in deciding who needs pacemakers. So it's basically done to check for AV conduction and see whether the block occurs below the His or above the His. And a subsequent step was taken by Dr. Hein J.J. Wellens, who is still with us today, from Holland. He took this, he and his colleagues, Dr. Dreher, did a wonderful thing. Not only now they could measure where the his bundle is, they could put more catheters into the heart and stimulate it, what they coined the term program stimulation. And now, by doing so, they could create and recreate and reproduce arrhythmias in the laboratory. I mean, today we can take it for given, but to be able to pace the heart and get into the electrical circuits and create certain re-entrant arrhythmias was a wonderful thing. And so this was still a big step. And I recall, because without finding where the arrhythmia is, you cannot treat it. And so this was another huge step. So surgeons took this message very seriously. Just like in any other areas in cardiology, surgeons were the pioneers. Even before PCI, we had CABG. Before TAVR, we had valve surgery. And so was the case with arrhythmia. Actually, there was a specialty called anti-arrhythmic surgery, which is a extinct term today. And surgeons use this information to map with the electrophysiologist where this arrhythmia could occur, and then they ablate or surgically dissect that extra pathways. So that's how electrophysiology began. And subsequent, now this was in the 70s, among late 70s to 80s, Dr. Scheinman took a huge step forward. Instead of having an open heart surgery to cauterize in the AV nodal area, he used a catheter introduced through the vein to the heart. And what he used was, he used like 200 joules direct current. He basically carpet bombed that area. And thereby, if you have an atrial fibrillation with rapid response and so refractory to you are not responding to, he put a catheter into the heart, who basically knocked out the AV node, and the patient needed a pacemaker. So this was the pioneer of catheter ablation in EP, and that was like early 1980s. So electrophysiology is relatively young specialty in that terms. When that happened, this is a slide I borrowed from Dr. Cox, who was a surgical pioneer of the Cox-Maze fame. And when catheter ablation was introduced, it was like having that meteorite into the dinosaur world where surgical ablation became extinct. And so everybody preferred the catheter-based approach. So this is again a slide I borrowed from him from 1970s to 80s. Surgical catheter ablation was going at an exponential rate until late 1990s. It almost came to an abrupt halt after catheter ablation was introduced. But now we see some resurgence of surgical ablation, particularly in some fields like atrial fibrillation. And where it will end, we don't know, but that time will show us. So what do we do in terms of electrophysiology study? I was asked to address a general audience, so please pardon me if this information is too simple to somebody. What we do is we introduce catheters, electrode catheters, that can sense the electrical activity in various chambers of the heart. And also we use these catheters to pace those chambers. So we gather a lot of information. And for an interventional cardiologist, I'm constantly reminded, this looks so crowded. Yes, we do have multiple catheters in the heart. And without that, we can't gather information. Catheters are generally placed in certain chambers, traditionally, right atrium, usually the high right atrium, and one catheter in the his bundle area, another catheter in the right ventricle, and then often a catheter in the coronary sinus. You heard that the coronary sinus goes toward the left side in the AV groove. That is to detect the signals from the left heart. And this is what we generally see. At the top, you see the PQRST, and corresponding to PQRST, we see in the high right atrium, you see the HRA, you see a signal corresponding to the atrial electrical activity. And in the third in the middle, that's the his electrode, where you see the middle signal representing the his bundle activity, which falls between the atrial and ventricular activity. And the last is in the ventricle. So, and we collect this information. So this is what an electrophysiologist will see in atrial flutter. I'm not going into details to describe that, but to the left is the intracardiac version of the sawtooth pattern that you see on the surface ECG. And you see a regular activity and representing here in the counterclockwise circuit along the tricuspid annulus. And as you see, as it takes a couple of turns in the atrium, few signals go down to the ventricle through the His bundle, so you may have 2 to 1, 4 to 1 conduction, and so on in the flutter. And that's what we see in the flutter. For example, this is another illustration of a left-sided accessory pathway where the circuitry goes from the His bundle down to the ventricle and back up through an accessory pathway to the atrium and so on. So with ablation, what we do here is we see the accessory pathway, even in this case on the left side, and you can see that electrical impulse goes to the His bundle as well as on the left side. And then once we introduce a catheter, often through a transeptal puncture or retroaortic, you try to get to that small area, which is often not even visible to the naked eye, and then find the spot where you have the accessory pathway, and then you ablate it. By doing so, you eliminate the pathway conduction. And this is what the surgeons achieved in the past with open heart surgery, which can be performed on by catheter ablation today. So the catheter ablation, we use predominantly radio frequency energy, which is to heat up. If the body temperature is 37, if you heat it up to about 50 Celsius, that's enough to desiccate the tissue. You don't have to boil the tissue at 100 Celsius. And that's enough to destroy that tissue in the localized region. Cryoablation, instead of heating, you can cool up, basically take away energy from the tissue, freeze it, and that can be used as well. The efficacy of each of these energy modalities vary and depends on the operator's experience and preference. So, for example, in cryo, cryo can be a catheter tip or a balloon, as I showed in this figure, and then when you freeze, the temperature drops, and basically you have the regions of freeze depending on how deep you can get. But again, once this occurs, the idea is that you leave a lesion, and the cryo lesions tend to have a more defined margins, and radiofrequency lesions tend to have a more ragged margins, but depending on the operator, I would say they are interchangeable for the most part. So this information can be used to treat various arrhythmias. Now, this was highlighted even yesterday. In the heart of ischemic heart disease, for example, in the left ventricle, if you see subendocardial scar, you can use these catheters to ablate. This is the same thing the surgeons did in the past. For example, if you have let's say, an LAD infarct, and your anteroapical region is pretty much non-viable and maybe even ballooning out, or maybe a pseudoaneurysm, that is a nidus, that is a site for VT. And the surgeons in the past used to pretty much dissect that area, take it out. So you take away the arrhythmic substrate. And the same thing can be achieved with the catheter today. Obviously you don't dissect, but you ablate that area. So other ablations are commonly used in the Western world today is for atrial fibrillation, which is a very common disease. And in this type of ablations, the primary target is the left atrium, particularly areas surrounding the pulmonary veins. My purpose here was not to get into details of any of these ablations, but to give highlight these. So catheter ablation is the closest to cure we can offer in many, many circumstances. And for many types of supraventricular tachycardias, including AV nodal reentry, atrioventricular reentry, or atrial tachycardias, the success rate of ablation can reach up to 90 to 95% with one procedure. And AV nodal ablation can be achieved pretty much 99% of the time. Ventricular tachycardia ablation in the setting of a normal heart, for example, like right or left ventricular outflow tract tachycardia, could be up to 90%. For ischemic ventricular tachycardia ablation, the success rate is lower, 70 to 80%, and atrial fibrillation, I would put in the ballpark of 50 to 70%. Now, how you define success is variable. I'm not going to details there, but just to get an idea what you can achieve. At what cost? Well, in general, AV nodal reentrant tachycardia can be associated with 1 in 200 chance of requirement of a pacemaker. Depending on how your protocols, you may end up with thromboembolisms, venous thromboembolism particularly, cardiac tamponade, or rarely death. And some patients, particularly the supraventricular tachycardia, the repeat procedural risk is 5 to 10%. If you have atrial fibrillation, the repeat procedure risk could be up to 30%, and the bleeding. So one has to make a risk-benefit calculation whether commit a patient to a pharmacologic treatment or no treatment versus ablation based upon the risk-benefit profile. But to know that ablation can provide a cure to some arrhythmias is quite reassuring, because what we do commonly in the way we practice medicines is we manage problems, we prolong lives. Why can we cure some arrhythmias? Because some arrhythmias are related to one small arrhythmic substrate, and once you eliminate that, the problem is solved. Not all arrhythmias, but some arrhythmias. So that's why the type of medicine we practice is good in fixing individual problems. But when it is multifactorial, we have to approach in a broader sense. So if it provides you a chance with a cure, whether you want to take it or not, it's a decision between you and the patient. Well, I'm switching gears. I hope I'm not exceeding time. I'm almost done. So that's about ablation. Well, what else we do in terms of interventions in EP? This was highlighted, and in electrophysiology, together with interventional cardiology, we do left atrial appendage occlusion. I was pleased to see that Dr. Mendis and the team had done one case of Amplatz occluder left atrial appendage occlusion recently. This is the Watchman, which is an FDA-approved device, which is exclusively used, in my way of looking at the world, is that patients who have a compelling reason to be on anticoagulation and also has a very strong contraindication for warfarin. For example, if you already had a stroke, embolic stroke, or at very high risk of stroke, and have almost an irreversible reason not to take it due to previous hemorrhagic stroke or still functional, this could be an option. And the promise of that is on that you occlude the appendage, which is the primary nidus of blood clots, and then the endothelialization occurs after about 3 months. And another direction we are heading into is a leadless pacing, which is introduced currently through the right femoral vein, and you leave a small bullet in the heart. It's currently available, these are commercially available products, in the single chamber. The advancements are being made in how to communicate with the top chamber, whether we can make it a dual chamber pacemaker or combine that with an ICD, but this is what we have today. So that was, I think, I wanted to say the last slide. So we have, going back to the future, from checking NADI, the pulse, today we also have a plethora of apps. Instead of going to Veda Mahatya and taking the pulse, now the patients come to you with his or her pulse and show you, this is my heart rate trending, with all the apps and the sensors that are attached to that. And that will give us a lot of necessary as well as unnecessary information. Be ready to absorb it and to figure out a system how to deal with it. And that's the future. I think the patients come to us with the problems in a different way. So again, I cherish this opportunity to thank you. I'll be happy to take questions at the end. Thank you.
Thank you very much, Dr. Mevan, for your nice overview of intervention in arrhythmias. If there's any question, we will take up at the end of the session. We will next move to the next talk, that is interpretation of pediatric ECG. It will be done by Dr. Amit Vora. Over to you, Dr. Vora.
How all of us would wish that children were just young adults, but children have to be different. In fact, today's generation, you greet them by WhatsApp, but they will greet only as up. They are completely sorted out, won't waste an iota of an energy. Let's sort out their ECGs. So essentially, how is a ECG different in children? And these are the list which we need to remember. First is they tend to have a higher sinus rate, often rate more than 100. Second is the QRS axis. The axis is rightward. The right ventricular is very markedly developed in the newborn because it has to work against the high resistance pulmonary circuit. So there is a right ventricular hypertrophy to begin with in the early stages of life. So axis deviation is there. There is a dominant R wave in right-sided precordial leads. There is a T inversion in lead V1 to V3. There might be some kind of an RSR dash pattern in V1. So this is because of their right ventricular hypertrophy, which is present at birth, which gradually resolves over a period of next few years. They tend to have marked sinus arrhythmia. Their vagal tone is also quite dominant. In general, their intervals tend to be shorter PR and shorter QRS duration. However, the QT interval, especially in the neonatal period, first 6 months of life, you need to realize that the QT interval might be longer, as long as 490 milliseconds, but beyond 6 months to 1 year, they would then normalize. And of course, because they are thin chest wall, often the ECG appears as if their voltage criteria is suggestive of a left ventricular hypertrophy. In terms of the rates, depending upon what age of child you take, the rates would be different. In the newborn, the rate can be 110 to 150 beats per minute. But in the first 2 years itself, there is almost a 15 to 20% drop. And subsequently, there is a 10% drop. So by the age of 6 years or so, they would come to an adult heart rate of 60 to 100 beats a minute. So as far as the QRS axis is concerned, in the first month of life, the QRS axis is markedly rightward, more than 110 degrees often, but it tends to come back more towards being plus 70 and plus 60 in the next 3 months to 3 years time. And eventually by 3 years, it again mimics more like a normal adult in terms of QRS axis. And in terms of T-wave inversion, we see that the T-wave inversion is there in precordial leads V1 to V3, and by 7 to 8, 9 years time, this T-wave inversion will go away and there will be an upright T-wave in the precordial leads as well. But we know that many of these children tend to have continuation of the T-wave inversion pattern in the precordial leads, which we call as persistent juvenile pattern. So in terms of this rate, axis, and the T-wave, a simple rule is 3, 6, and 9 years. So the QRS axis normalizes by 3 years, the heart rate stabilizes to an adult by 6 years, and the T-wave inversion stabilizes by 9 years of age. Now this is all good, but the best way is to try to look at the ECGs and implement this information which we have. So let's look at this ECG of an infant. And what we clearly see is that there is a sinus tachycardia, 110, 20 beats a minute. You see the QRS axis is rightward. In the precordial leads V1, you see an RSR dash pattern, T wave inversion from V1 to V3. So this is a physiological ECG for an infant, normal. At 5 years of age, what is going to happen is that the QRS axis we said should normalize. So now you look at lead 1 and AVF, which help you to determine the QRS axis, and you see the axis has normalized. T-wave inversion we said is going to take a longer time, so you have T inversion persisting in lead V1 to V3. But look at the RS ratio in V1, V2. The tall dominant R wave, now the RS is becoming more equal, or the S might slightly become dominant. And eventually by 10 years, we said this is going to look like a normal ECG with T wave being upright in the precordial leads, axis being normal. However, you see the precordial lead, the voltage looks high. The voltage tends to look high because of the thin chest wall of these children. I think with this information, let's look at certain case examples where we need to pick up two abnormalities in children. One is presence of congenital heart disease, and the second is any rhythm disturbance. So this is the ECG taken in 1.5-year-old child who's breathless. 1.5-year-old child. So let's look at the QRS axis first. QRS axis we said will normalize by 3 years of age. What is the QRS axis here? It is not rightward. We said that the voltage wise, the RS ratio in lead V1 should be R taller than the S wave. That is not the case. In fact, you have a tall R in V5, V6, you have a normal or a leftward QRS axis, you have RS pattern showing a dominant S in V1. So these are in fact showing criteria of a left ventricular hypertrophy in this child, and when an echocardiogram was done, it was found that this child had a coarctation of aorta. Another example of a 3-year-old child who's not growing well, not gaining weight, not feeding well, and this is the ECG that's done. Again, if you look at the QRS axis, this is a clear-cut leftward QRS axis. It's a left axis deviation in a 3-year-old child, not acceptable. Something is wrong with his heart structurally. What about the precordial leads? Again, instead of a dominant R wave, you have a QR pattern in V1 and V2. Presence of Q in V1 and V2 is pathologic. Children can't have a Q wave, even adults can't have a Q wave in V1 and V2. And if you look at the Q waves in V5 and V6, again, they're tall, deep Q waves there, more than 5 millimeters. So this ECG is abnormal. Left axis deviation, ventricular hypertrophy is seen, right ventricle as well as left ventricular hypertrophy, needs an echocardiogram. It showed an AV canal defect with significant valvular regurgitation. So when in children will we consider abnormal Q waves? Because it's, because of the voltage enlargement, you can see sometimes the depth of the Q wave also being there, especially in V5, V6. So the Q waves are abnormal if they are more than 5 millimeters deep, or if they are wide, more than 40 millisecond or one small square. Any Q in V1 is abnormal, and no Q wave in V5 or V6 is also abnormal. So this is the pattern you should be able to pick up in children when you're doing the ECGs. Let's look one last example of structural heart disease. This was a 10-year-old child, easy fatigue, has presyncope also. This child has a right axis deviation. So right axis deviation persisted much longer period and time in this boy. And you have T-wave inversion in inferior leads. You have a very tall R wave in V1. There is no normalization pattern whatsoever of getting a deeper S wave. So this is clearly an example of RV hypertrophy and strain in a 10-year-old child, and this child in fact had a primary pulmonary hypertension. Another pattern which we often see and at times confusing, this is an adolescent child been complaining of atypical chest discomfort, and this is the ECG. And So in terms of overall, the ECG looks fine, but often the question comes up is this early repolarization changes. If you look at lead V4, V5, and V6, you have slight ST elevation, concave ST segment, and early repolarization. So early repolarization, when is it normal, when is it malignant? This is an important question which needs to be addressed these days. More often than not, if you have early repolarization changes in the lateral leads, it's likely to be benign. If this early repolarization is not associated with a prolongation of the QT interval, it is benign. If the early repolarization does not show a downward ST segment, it is benign. If it does not have short coupled PVC associated, it tends to be benign. The rest are the ones which could be malignant and which could be similar to what is seen in idiopathic VF patients. Also, the amplitude of the T wave is important. So how high is the J wave as compared to the T wave? So T wave to R wave ratio is also important. Those who have malignant, they don't have a tall T wave, but the early repolarization benign varieties tend to have a tall T wave as well. The Fishhook pattern is classic, what is described in early repolarization syndrome. And there is an autonomic variation to this early repolarization changes, but more often than not, the pattern remains more or less the same. It's not very fluctuant, apart from the minor changes with the heart rate. And more than 1/3 of the people will outgrow these early repolarization changes as they go into adulthood. But yes, it can become a differential diagnosis also for pericarditis. Pericarditis generally will have ST elevation in almost all the leads except AVR. Pericarditis also will have PR depression, and SCT ratio is also abnormal in pericarditis. And of course, there would be an evolutionary pattern. Let's look at some of the rhythm issues in children. Now, this is of a 8-year-old child who underwent a Holter study because of complaining of some palpitations. And this is the bradycardia that got noted in this child. What is this bradycardia due to? Is this a sinus node dysfunction or an AV block? If you see the ECG carefully, you can see P wave, QRS. Unfortunately, I don't have a pointer. The second QRS, which is very visible where the bradycardia is marked on the Holter, also shows a P wave preceding, but this is a prolonged PR interval now, and the third P wave is dropped. So essentially, it's a AV Wenckebach phenomenon. So now the question is this AV Wenckebach malignant enough? The heart rate has gone down to as low as 38 beats a minute. Should we give a pacemaker to this child? Well, it's very important that what time of the day this was there. It was 1:30 a.m. in the night. Children tend to have a high vagal tone at night time, not symptomatic at all. This is physiological. This does not require a pacemaker at all. The child never complained of pre-syncope, syncope, and at other times you see the AV conduction is also good and the sinus rates go as high as 140, 150 beats a minute. This is a 4-year-old child who underwent a non-cardiac surgery, as in recovering in the pediatric intensive care unit. And suddenly the child woke up, was crying, and this marked tachycardia seen. Tachycardia which is almost to the tune of 200 beats per minute. Now in this strips, the first is an ECG, the second is a pulse oximeter waveform that is seen. So in the first strip, when it was seen, the immediate reflex of the intensivist in the pediatric unit was to consider giving adenosine, because this looks like a supraventricular tachycardia, heart rate beyond 200 beats a minute. But well, you need to be careful. With a heightened sympathetic tone, post-surgery, this may be a sinus tachycardia also. So look at the ECG when the child is a little quiet, and gradually if you see in the second and the third strip, the T and the P are separating out. So in the first strips, the P was merged within the T wave, not very well identifiable, I can grant that, but in the bottom strips, the P and T is separating out. So this is nothing but sinus tachycardia. Unfortunately, they gave adenosine to this child, which was completely unwarranted. So be able to realize that some of these arrhythmias are completely benign and don't need any particular treatment as such. Example of a young adolescent girl who's been complaining of palpitation, chest pain. The mother takes her to the general practitioner. He examines and finds everything normal. Repeatedly this happens. Every time she complains, goes to the doctor. By the time going to the doctor, doctor finds everything is normal, and she's been labeled to have anxiety and stress related to, studies and stuff like that. But we need to be careful. There have been situations where, they have been labeled as neurotics and have been, in fact, started on some anxiolytic treatment also. But palpitations, tachyarrhythmias can be completely paroxysmal in nature, and you need to go into the history more details. One fine time, a Holter monitoring did pick up that she gets into supraventricular tachycardia. So there's a paroxysmal supraventricular tachycardia, except that all this while it was lasting few minutes, not being picked up on any test. And obviously clinical examination of a patient with SVT is going to be completely normal. So not to miss out on a classic history and need to have appropriate workup done to pick up supraventricular tachycardia. This is an ECG which is again of a child, and this is quite an abnormal ECG. If you look at lead V5, V6, there's a Q pattern seen in V5 and V6. There's no R wave. If you see lead V2 and V3, there is a tall S wave. There's a left axis deviation. There's a 4-year-old child, completely abnormal. So suggestive of a biventricular hypertrophy, and this child in fact had a hypertrophic cardiomyopathy. What I want to point is what is normal in this ECG. If you look at the rhythm strip, look at the RR interval, there is quite a bit of variation in the RR interval, and it was thought that there is some kind of a sinoatrial block or AV block happening in this child. But believe me, this is atypical sinus arrhythmia. An atypical sinus arrhythmia is quite common and physiologic in children. It can happen very frequently, giving rise to bizarre, erratic RR intervals. They don't, 50% of the times, sinus arrhythmia is not typical in nature, where it's gradual acceleration and deceleration noted. A 5-year-old, every time when she's getting ready in the morning for getting prepared to going to school, has had fainting spells, some of them have seizures, and she's been seen by a neurologist. Obviously a CT scan, MRI, EEG, everything is done for the syncope and seizures, and as you would be aware that all these tests are completely negative, and then a cardiologist is involved as to what's happening, and what you need to do is just take a 12-lead ECG. And what does this ECG show? Anybody? Marked QT prolongation. There's a marked QT prolongation such that in fact, you can appreciate some amount of T wave alternance. If you see in lead 2, small T wave, large T wave. Similarly in V5, small T inversion, big T inversion, and a prolonged QT. Eyeballing, if the QT interval is more than 50% of the RR interval, it would mean that the QT is prolonged. And this long QT syndrome can be a life-threatening arrhythmia, and today's syncope or seizure can be a sudden death, needs to be identified and needs to be appropriately treated. So in children, when they complain of syncope, syncope is almost always cardiovascular. There's nothing to do with brain. The definition has to be correct. It's a transient fall with spontaneous recovery. And in such situations, you need to do an ECG. What you should look for in ECG is left ventricular hypertrophy, pre-excitation pattern, long QT, any evidence of chamber enlargement and structural heart disease, or even a complete AV block. So these are the things you should look for. And this is a child who again had syncope, but also palpitation and syncope both. And this is a pattern recognition. What does this ECG show? What is this tachycardia? It's a very fast tachycardia. It's a very broad tachycardia. It's irregular tachycardia. Fast, broad, irregular. Hein Wellens has taught us that this is atrial fibrillation with WPW syndrome. And this is also an arrhythmia which needs to be picked up early and treated appropriately so that they don't land up into a ventricular fibrillation and sudden death. Because in these children with WPW, where AFib with rapid rate is happening, the bombardment of the ventricle can be at a very rapid rate, leading to VT, VF, and sudden death as well. An infant who again has problems in growing up, not feeding well, excessive crying, sweating is noted, and you took at the ECG. The ECG looks like a tachycardia. There's a tachycardia going on. Is it sinus or not sinus? Becomes the question. And therefore, you need to look at the P waves more carefully. And often, when the sinus tachycardia is there, the P wave can get merged into the T wave, giving you this inability to be very certain whether there is sinus tachycardia or there is any other atrial arrhythmia. And you need to look at it more carefully. And I have marked it in lead 2. If you see, there are in fact 2 flutter waves between one QRS, and this is a flutter, atrial flutter with 2-to-1 AV conduction that is going on. And this rhythm also needs to be treated because persistence of this rhythm can lead to problems. Let me show you one of the last examples of a 7-year-old child who actually presented with heart failure. If you see the X-ray, the cardiomegaly was significant. Echocardiogram showed ejection fraction of 15%. And on the ECG, she had this kind of a heart rate going on, 140, 150 beats a minute, constant, steady heart rate of 140, 150 beats a minute. So the question to you is that, is this heart rate sinus tachycardia and consistent with the heart failure? Or is this an abnormal tachycardia which is causing the LV dysfunction? Tachycardia-induced cardiomyopathy in children needs to be thought of very early. You have to have a high index of suspicion. So what we need to look at is the morphology of the P wave. And the morphology of the P wave, if you see, what is abnormal is in lead 1, you almost see a flattish kind of P wave, very low amplitude P wave. If you see in lead V1, V1 always should show a biphasic P wave. Here you have a monophasic P wave happening. This would mean that this is most likely an atrial tachycardia, and in fact was taken up for radiofrequency ablation. When it terminated, you got a sinus rhythm, and in a short span of time, you had normalization of the ejection fraction, and the cardiomegaly also regressed. So tachycardia-induced cardiomyopathy is a treatable arrhythmia by radiofrequency ablation. I think I'll leave you with this last slide. When you have tachycardias in young children, it's a reflex action to say that this must be an SVT because it's a young child. But again, look at the patterns. If you have an RBBB-like tachycardia with a left axis or a northwest axis deviation, very likely it's a fascicular VT or VT arising from the left posterior fascicle. And this again behaves or mimics the natural history of a SVT because IV verapamil or verapamil is a drug of calcium channel blocker, a drug of choice, and they can be also successfully treated with radiofrequency ablation. I think I'll stop here. Thank you very much for your patient listening.
Thank you very much, Dr. Amit Vora, for that enlightening lecture. The next lecture will be done by Professor Andrew Boyle. The topic is on how hemodynamic assessment in cath lab helps in patient management. Over to you, Professor Andrew Boyle.
Thank you very much. Okay. So I'd like to start this talk with some history, just like the last one. And cardiac catheterization in humans began in 1929 with an ambitious young German surgical resident by the name of Werner Forssmann, who was told, "You're not allowed to catheterize a human being." So he went against his seniors and he decided to perform a cardiac catheterization upon himself because he believed so strongly it could be done. And he used a urinary catheter through the brachial vein. He convinced a young surgical nurse to steal some gear from the operating theatre and help him in the middle of the night. And he cut down his own brachial vein and passed this catheter and went to the radiology, and under X-ray guidance he passed it up to his heart, and that's the X-ray of the original cardiac catheterization. And he was subsequently fired and ironically became a urologist, but he won the Nobel Prize for that. Cardiac catheterization evolved further with the discovery, or accidental discovery, of coronary angiography in the 1950s. And Mason Sones at the Cleveland Clinic was famous for discovering coronary angiography. And then cardiac catheterization really took a turn to become more a coronary-focused procedure. So between the, in the era of the 1950s and 60s, a lot of diagnostic strides were made with structural heart disease using cardiac catheterization, and then focus shifted in the 70s and 80s towards coronary disease with angioplasty and Andreas Grunzig there. And so as we see coronary heart disease in the red line at its peak in the 60s and 70s with bypass surgery and angioplasty, we kind of forgot about hemodynamics and focused a little too much, I believe, on the coronaries in the Western world. But I believe there's still an important role for hemodynamics in the cath lab, and I'll start with a case here, which was last month. A 71-year-old female who presented with central crushing chest pain at 11:30 in the morning. She'd never had this chest pain before. She was nauseated and diaphoretic, and the ambulance said she looked unwell and she was hypotensive at the scene. She had a history of risk factors for coronary disease with type 2 diabetes, depression, hypertension, hyperlipidemia, and some other medical illnesses. She was on a host of medications which are not really pertinent, but what's important is that she was a little hypotensive at the time. She had an ejection systolic murmur and a pansystolic murmur on examination in the emergency department, but she was not in pulmonary edema, and this was the ECG, I'm sorry. So what would you do with this ECG in a woman with new onset chest pain and all the risk factors? Cath lab? Okay, so she was taken to the cath lab for a primary PCI, and here's the coronary angiography, and it reveals relatively normal coronary arteries. They're large and tortuous coronary arteries with fairly slow flow, but there's no obstructive lesion in the LAD as was expected. The right coronary artery has some plaque in the proximal vessel, but again, no obstructive disease. And left ventriculography was performed at the time, which revealed the diagnosis. What's the diagnosis? Takotsubo, excellent. What else do you notice on that ventriculogram? Well, I think it's noteworthy for quite a degree of mitral regurgitation into a left atrium that's not particularly enlarged, and even some flow back into the pulmonary veins, which is a little bit unusual, but fits with the examination finding of a murmur. And then when removing the pigtail, this hemodynamic trace was recorded. Does anyone want to say what that shows? So I can tell you the pigtail catheter crossed the aortic valve very easily. But what this shows is a severe gradient from the left ventricle, so the left ventricle systolic pressure is 160 or 170, and the arterial or aortic pressure is 70 or 80 systolic. So there's a 100 millimeter mercury gradient there, but the valve was very easy to cross. Sorry? Sorry? Subaortic obstruction. All right, and what you'll notice then, I think you're talking about, is the upstroke on the left ventricular pressure trace is abnormal, and the aortic upstroke is normal. So it doesn't look like aortic stenosis. This is the echocardiogram, and you can see that she's got the classic findings of Takotsubo with apical akinesis. Can you loop that video, please? But what you can see here is there is hyperdynamic function of the basal septum, and there is systolic anterior motion of the mitral valve. So this woman has developed dynamic outflow tract obstruction due to the hyperdynamic function of the basal septum in the context of Takotsubo. I'll just go on to the next video. There's a close-up, and you can see the systolic anterior motion there of the mitral valve, creating a dynamic outflow tract obstruction. And you can see the jet in the left ventricular outflow tract shows an aortic valve. Where are we? The mean pressure gradient of 48 millimeters of mercury. So confirms what we found in the cath lab. Now, this woman had a systolic arterial pressure in the 70s and was being treated with adrenaline and noradrenaline to maintain her blood pressure. Do you think that was helping in the context of Takotsubo cardiomyopathy? No, of course not. And so the hemodynamics made the diagnosis here. So how would you treat this? So the treatment of dynamic outflow tract obstruction is to stop the catecholamines, give beta blockers, and give intravenous fluid, despite the elevated end diastolic pressure. Okay, and the ICU doctors looked at us like we had two heads, but that's exactly what was done. And here, 6 days later, the repeat echocardiogram shows she still has some akinesis at the apex, but the systolic anterior motion is gone. And now the pressure gradient is 8 millimeters of mercury. So in an inadvertent hemodynamic study, found an unusual pathology and completely turned our management on its head, and the patient did remarkably well. So this is a stress cardiomyopathy in a patient with underlying mild left ventricular hypertrophy, where the hyperdynamic basal function during the stress cardiomyopathy caused dynamic left ventricular outflow tract obstruction with significant mitral regurgitation. She was hypotensive in cardiogenic shock, despite her left ventricle generating a blood pressure of 170 millimeters of mercury. And so the treatment is to avoid inotropes, give beta blockers to reduce the outflow tract obstruction, give fluids, and potentially even give alpha blockers, that should read alpha agonists, to increase the afterload, or even a balloon pump temporarily. And so she did well and was discharged home from hospital. Okay, change gears a little bit. Left ventricular end diastolic pressure is a very easily measured hemodynamic parameter in the cath lab. And so we've looked at this in ST elevation MI, and I showed this picture earlier during my heart failure talk, but it's important to remember this law of Laplace shows that the wall stress of the left ventricle is proportional to the pressure in the left ventricle, as well as the size of the chamber, and inversely proportional to wall thickness. Okay, so the pressure in the left ventricle is something we might be able to impact on. It's very easily measured. It's measured at the inflection point after the A wave in diastole, and it corresponds to the R wave on the ECG. It's best measured at a 50 millimeter scale and a 50 centimeter per second sweep speed. And so we looked at the literature on this, and in the current era of primary PCI for STEMI, there's only 3 studies which have looked at the prognostic value of end diastolic pressure. And they showed on the left that patients with an end diastolic pressure above the median had a 1.9-fold increased risk of death. And patients with an LV EDP above the median had a 2.9-fold increased risk of heart failure hospitalisation. So even in the modern era of rapid reperfusion in primary PCI, it still holds prognostic information. We accessed another data set, and this is interesting now. The National Heart, Lung and Blood Association in the United States have a program called the BioLink program at that website, where you can access multiple clinical trial data sets for free. So if you have a clinical question, the clinical trial protocols are published with all the endpoint definitions. And if those data sets suit you, you can request the data, which is what we did, because we were looking for a data set with left ventricular end diastolic pressures measured in the cath lab at the time of STEMI and outcomes. Now, some of you might remember the TIMI-2 study. It's back in the 1980s. It was a study of 3,339 patients who had received thrombolysis for ST elevation MI and were then randomized to conservative treatment versus early cardiac catheterization. They were all on aspirin and beta blockers, but no statins or ACE inhibitors in those days. So we took those who had the early invasive arm and had an open artery from successful thrombolysis as a kind of surrogate for the modern patient with early reperfusion. And we found 1,200 patients in that group, and their median left ventricular end diastolic pressure was 18 millimeters of mercury. And we looked at the prognostic value there. And we showed that they had, those with an EDP above 18 had double the mortality and triple the risk of heart failure hospitalisation in the subsequent years. And that was exactly what had been shown in the more modern era, but reflected in a larger data set. We looked by quartiles, And in fact, it was the highest quartile with end-diastolic pressures over 25 millimetres of mercury, which had the highest mortality, and we saw a dose-dependent effect on heart failure. In this study, there was a poor correlation with ejection fraction. So this is an interesting observation about prognosis, but does it change your management? Will targeting patients with elevated end-diastolic pressure for intensive heart failure management improve outcomes? Can you even lower the end-diastolic pressure? And if you can, is this safe in the immediate post-STEMI setting? So we went about addressing this, and we performed a phase 1 study to look at the feasibility and safety of lowering end-diastolic pressure. And so we took patients who came to our cath lab for primary PCI and had an elevated end-diastolic pressure after primary PCI, and we chose a cutoff of 20 millimetres of mercury based on all of the literature together. And we gave some of them intravenous furosemide, a single dose, plus escalating doses of nitroglycerin, so 100 mics per minute for 10 minutes versus saline control. And of a total of 114 patients, we excluded a number for various reasons, but we had 10 in each of these groups. And we showed in the unbroken lines the treatment resulted in a reduction in end-diastolic pressure in all patients. And in fact, if you look at the numbers, the median went from about 26 down to 16. So taking all patients from the elevated EDP group to the below the median group. And in the control in the broken lines, there was absolutely no change in end-diastolic pressure. There was some trade-off. The blood pressure was slightly lower. It dropped by about 16 millimetres of mercury, but only one patient developed a blood pressure below 90. And interestingly, we found absolutely no correlation between ejection fraction and end-diastolic pressure. So we feel that you are able to target the highest risk patients with an elevated EDP in the cath lab. We showed that you can successfully lower end-diastolic pressure, acutely at least. But the question is, does that translate into better outcomes for these patients? So that's the subject of our ongoing phase 2 randomised double-blind placebo-controlled trial, which is a 3-month trial looking at remodelling endpoints with cardiac MRI. And if this is successful, we'll head on to a multi-centre phase 3 study. And in this same space, there are lusotropic drugs in development, a number of places around the world, which may have long-term impact on remodelling outcomes. So I think hemodynamic studies in the acute setting are important for prognosis and are really re-emerging in the modern era. Okay, different hemodynamic study, aortic stenosis. There's a renewed interest in aortic stenosis in the TAVI era, and I think in straightforward cases of severe symptomatic aortic stenosis with a clearly elevated echo transaortic gradient with a normal ejection fraction, it's reasonable to proceed directly to surgery or TAVI, and you don't need a hemodynamic evaluation of the valve. But I think in the more complex subsets, you really need a complete hemodynamic evaluation. And those subsets include patients in atrial fibrillation, patients with poor acoustic windows for echo, and patients with low flow, low gradient severe aortic stenosis, or patients in whom you're worried about that. So I think a complete evaluation requires a couple of things. Firstly, a right heart catheterization to accurately determine cardiac output to give you a measurement of aortic valve area. And secondly, simultaneous pressure measurement from the LV and the aorta. And that can be done either with 2 arterial access sites or with one of these double lumen catheters. And they come in pigtail or straight shapes. And what you get is something like this tracing, and if you have a look, the red tracing is the LV and the green tracing is the aorta. And when the pigtail is pulled back into the aorta, there's a substantial change in the aortic pressure with pressure recovery. So if you're just doing a pullback gradient, you don't know really where to take that aortic pressure from. And so that's subject to inherent limitations and error of the test that's easily overcome with a double lumen pigtail catheter. So I think that's mandatory for quantification of aortic valve stenosis. And this entity of low flow, low gradient severe aortic stenosis has really come to the fore in recent years. About 80 or 90% of aortic stenosis are classic high gradient normal flow AS. But there's a group on the right with low flow, low gradient aortic stenosis in whom an impaired left ventricle in the context of mild to moderate aortic stenosis present a diagnostic dilemma. So is that low gradient due to mild to moderate AS with normal output? Or is that low gradient due to severe aortic stenosis, but the ventricle is not functioning well enough to generate a high gradient? And so that's the classical low flow, low gradient dilemma. But there's also an emerging realization that in the context of a normal ejection fraction on echo, you can still have a low cardiac output. And these are patients with restrictive cardiomyopathies, severe LVH from age and aortic stenosis, who have a normal ejection fraction but a low output, low gradient, severe aortic stenosis. So how do you sort these out? Well, this is one paradigm to sort out the classical low flow, low gradient aortic stenosis. And this is in patients at the top with an ejection fraction of less than 40% and a pressure gradient of less than 40, but a calculated area that would suggest aortic stenosis. You do a dobutamine stress echo. If on the left you get an increase in stroke volume of more than 20%, that indicates you've got flow reserve in your left ventricle. Okay? And if your stroke volume picks up and your gradient increases, then you have true severe aortic stenosis. And the problem had been that your ventricle was not functioning well, and the dobutamine has shown you that. But if your ventricle increases and you have a more than 20% increase in stroke volume and the gradient remains low despite improving your ventricular function, you do not have severe aortic stenosis, and it's medical therapy for heart failure. The problem remains in those who have no flow reserve on the right of screen, whose stroke volume does not improve by more than 20%. And then you either have pseudo-severe AS or you have true severe AS. This protocol recommends the calcium score to differentiate those, and I think that's a little bit blunt. But the concept of improving the left ventricular function and remeasuring the gradient's an important one, and I think that can be done better in the cath lab than in the echo lab. So to summarise that busy slide, distinguishing classical low-flow, low-gradient aortic stenosis from pseudo-aortic stenosis in the cath lab requires an accurate measurement of cardiac output and stroke volume, simultaneous left ventricular and aortic pressure, a dobutamine protocol similar as for echo, and then reassess the aortic gradient, cardiac output and stroke volume index after dobutamine. And it's particularly important in cases where echo sampling error occurs, such as atrial fibrillation. And I believe it's better done in the cath lab than the echo lab because you can define the coronary anatomy, and ischemia is one of the reasons to fail to augment with dobutamine. Okay, so not ruling out ischemia is a real pitfall of the dobutamine echo approach. There's another way in the cath lab where you can sort out this paradoxical low output, low gradient state. And so in patients with severe hypertrophy or restrictive cardiomyopathy who have very stiff aortas and peripheral vasculature, you'll have a false elevation of the aortic pressure. And you'll see at baseline on the left, the high aortic pressure is reducing the gradient across the valve. But with sodium nitroprusside infusion, a valve gradient of 45 millimeters of mercury, which has become severe, is uncovered there. So I think that's the only way that you can really distinguish that clinical entity safely. And it matters for prognosis. So I'm getting the time wind up here. So I'll finish there a little early, and we'll have questions at the end. Thanks very much.
Thank you very much, Professor Andrew Boyle, for your excellent presentation. Now the forum is open for questions. Can I ask all three speakers to come to the stage for the discussion? Because of the time limitation, we won't be able to have a lengthy discussion. We can allow only 1 or 2 questions if you have.
This question is for Dr. Amit Vora. I think we quite often see T inversion in V1, V2, V3 in our clinical practice, especially in the adult cardiologist patients. In those patients, when should we be concerned? You're talking about juvenile pattern of ECG. But we do see in adult patients, like especially young adult 20s, 30s, V1, V2, V3 teen versions. Sometimes we are worried about arrhythmogenic right ventricular hypoplasia in those patients. So when should we be concerned in these patients?
So persistence of juvenile pattern can happen in a significant number of people, and almost 1/4 might have this beyond 20-25 years of age as well. What is important to differentiate it being physiological versus pathological is correlation with symptoms and fluctuation in the T-wave pattern. If you have a T-wave inversion which is native to that person, and especially in middle-aged ladies, we often see, it's a persistent T-wave inversion of the same nature all through. So a serial ECG or ECG compared previously over a few years, you see the same pattern. That is completely physiological and benign. But if you have a fluctuant T-wave happening, and if you have a correlation with the ECG or your clinical or echocardiographic examination, then is it pathological.
Patient with a positive stress test and the coronary angiogram is normal, would you propose any form of catheterization or hemodynamic measurements on these patients?
Well, I guess it depends on the clinical setting. But if someone has a positive stress test, positive functional study, and normal coronary angiograms, people have done index of microvascular resistance, which is an invasive flow wire-based measurement, and shown that particularly in middle-aged women with that coronary syndrome X, that's very abnormal. And that reflects microvascular abnormalities, not epicardial stenoses. And how we treat that is still unknown. But in general, it's with vasodilators like nitroglycerin and calcium channel blockers. Do we routinely do that in practice? No. If we see slow flow in the epicardial coronaries, I would treat with vasodilators if the patient had ongoing chest pain, but otherwise, no.
Yeah, Dr. Boyle, this, in your lectures you mentioned about this STEMI situation, EDP, and we all know that ejection fraction is more sensitive to prognosticate short and long-term events. But what do you think? EF is more sensitive, or the EDP is a sensitive indicator of prognosis?
I think they tell you different things. And in the TIMI-2 study, we've done several statistical models as to which contributes most to prognosis. And ejection fraction probably contributes a little more. But if you look within the subset that had a normal ejection fraction, the EDP still predicts who's going to die or have heart failure. So I think EDP gives you a reading of the volume loading and the general health, both diastolic and systolic health of the ventricle. And the ejection fraction purely looks at systolic function. So the answer is they both contribute. Yeah.
Okay, right. Thank you very much once again for all three speakers. We have to conclude our sessions here. Shall I invite Dr. Saki to give the token of appreciation to Dr. Mewan Wijetunga? Okay, thank you very much.
Thank you, chairpersons and the guest speakers. And now, for the next segment of our lineup, we are moving on to a very special award. This is the Dr. Pramod Ranatunga Memorial Research Award. I invite Dr. M.R. Mubarak, Professor Aswar Zaman, and Dr. Kumudini Ranatunga to chair this session.
We have come to a different session now. All this time, the experts were talking to us, and now it's a young blood is going to talk about what is being done. Dr. Pramod Ranatunga Memorial Research Award. When we took over office last year, our council felt that we should promote research and studies among the cardiology community. In that sense, we worked hard. Our editor, Dr. Sepalika, worked hard with Dr. Ruwan Ekanayaka, and we published the first issue of the journal at the inauguration. This is another study. We wanted to have a research award at the inaugural session, at the annual sessions. And at that time, we discussed, and Dr. Kumudini Ranatunga, wife of Dr. late Pramod Ranatunga, volunteered. He donated a generous amount of money to our association to give an annual award of rupees 100,000 plus a gold medal to a research awardee who is presenting a good paper at the sessions. So this is the time where we should remember Dr. Pramod Vishwabandhu Ranatunga, MBBS, MD, FRCP London, FCCP Sri Lanka. Dr. Pramod Ranatunga had his primary secondary education at Nalanda College, Colombo, where he was a senior prefect and was selected the most outstanding student of the college in 1975. He was also the captain of the school general knowledge team. He received his undergraduate education at the University of Peradeniya during 1979 to 1985. During this time at university, he was awarded distinctions in pediatrics and community medicine, and also received Wenderstraten Gold Medal for Community Medicine and the Panabokke Prize for Forensic Medicine. During at that time, I first met Dr. Pramod Ranatunga. At that time, we call him Pramod. I think Dr. Gotabe was also know him, and he was the secretary of the medical association at that time, medical school time. And we used to see him as an active secretary working for, and we have been respecting him at that time. He was at the final years. He completed his local postgraduate studies and obtained MD in general medicine in 1990. He underwent postgraduate training in special pediatric cardiology at the Leicestershire Regional Centre in West Midlands and adult interventional cardiology at the Regional Cardiothoracic Centre, Walsgrave Hospital, Coventry in the UK. Dr. Pramod Ranatunga was the General Secretary of the Sri Lanka Heart Association from 1996 to 1999, and the Joint Secretary of the Ceylon College of Physicians from 1999 to 2000. He worked as a resident cardiologist at the Institute of Cardiology until his demise in 2005. He has involved in performing the first interventional procedures in the country, especially the percutaneous angioplasty, device closures, etc. Dr. Pramod Ranatunga was a warm, generous, kind-hearted person who had an outstanding human qualities with his fine moral values. He was a very popular clinician, cardiologist in the country at that time. So in memory of him, Dr. Mrs. Kumudini Ranatunga has decided to give a research award to the Sri Lanka Heart Association. So when the applications were called, we received an application for research award. So this research paper was sent to Professor Azhar Zaman for his review. I call upon Professor Rahman to give his review about this paper.
Thank you. So I received this paper for review as part of this award, and I'm delighted to say that it follows on from the talk that I was asked to give earlier about cardiac rehabilitation. So this paper by Dr. Jayawardena and colleagues is about local cardiac rehabilitation in a hospital in Colombo, and it's based at the Centre for Diabetes, Endocrinology and Cardiac Metabolism in Colombo. So we've known about the benefits of cardiac rehabilitation since 1973, and I've told you about the downsides of attendance and getting patients to attend. But equally, if it's going to be successful, it has to be successful based on local health needs and the local population. And this is what stands out about this paper in particular. So according to this paper, cardiac rehabilitation is not popularly practiced in Sri Lanka. There are one or two hospitals, particularly the National Hospital of Sri Lanka, the teaching hospital at Kandy, where there are cardiac rehabilitation facilities provided by the state sector. But one of the problems, well, several problems, is the lack of referral by cardiologists or physicians and a lack of awareness of the benefits of cardiac rehabilitation in patients undergoing coronary revascularization or with other cardiac conditions such as heart failure or stable disease. So the CDEM hospital in Colombo is the first leading hospital in the private sector in Sri Lanka that provides outpatient cardiac rehabilitation programs. And Dr. Jayawardena and colleagues studied 39 patients who underwent cardiac rehabilitation. And the great thing about this project was it wasn't just led by the cardiologists, so it consisted of a multidisciplinary team that included cardiologists, physicians, psychotherapists, physiotherapists, and nutritionists. They selected 39 patients, the majority of whom, 69%, had undergone PCI for stable coronary artery disease. The endpoint over this period was the 6-minute walk test, quality of life as assessed by a questionnaire, lowering of low-density lipoprotein, maintenance of a systolic blood pressure to below or equal to 130 millimeters of mercury, and a glycosylated HbA1c of 7 or less. At the end of their study period, they showed that if these patients were adhered to this cardiac rehabilitation program in this multidisciplinary approach, that the 6-minute walk test at the end increased from 545 meters to 687. There was a significant improvement in quality of life. 90% of the patients who completed the course had lowered their low-density lipoprotein levels to below 100 milligrams per deciliter. 90% of the patients adhered to a lowering of blood pressure of 130 millimeters of mercury or less. 90% of patients had HbA1c of 7 or less at the end of the program. Importantly, all patients, 100% of patients, reach their reserved heart rate on exercise of at least 80%. So this is hugely encouraging for the local population and provides a bedrock from which other centers in Sri Lanka can use to start their cardiac rehabilitation program. And it gives me great pleasure to have selected this research project for this award that Dr. Mubarak has informed you of. Thank you.
Thank you, Professor Zaman, for this excellent review, and thank you on behalf of the Heart Association for doing this job. Now I call upon Dr. HMCP Jayawardena to receive her award and the gold medal from Dr. Mrs. Kumudini Ranatunga. Now I call upon Dr. HMPC Jayawardena to read her paper on experience of cardiac rehabilitation program in a private sector institution in Sri Lanka.
Good afternoon. It's a great honor and a privilege for me to be here today. I sincerely be grateful for Sri Lanka Heart Association for giving me this opportunity to present my paper. This is experience of cardiac rehabilitation in private sector Sri Lanka. As all of you know, this is the WHO definition of cardiac rehabilitation. It's the coordinated sum of interventions required to influence favorably the underlying cause of cardiovascular disease, as well as to provide the best physical, mental, and social conditions so that the individuals may, by their own efforts, preserve or resume optimal functioning in their community and through improved health behavior, slow or reverse progression of disease. Cardiac rehabilitation has Class 1 Level A recommendations in 2016 European guidelines, but it is underutilized globally due to various reasons. Main reasons are lack of referrals, low enrollment rates, low completion rates, also considerable disparities in access, and lack of social support and self-esteem. But in Sri Lanka, we have good cardiac rehabilitation programs, especially at National Hospital Sri Lanka, Teaching Hospital Kandy, Kurunegala, also Base Hospital Avissa Vella, General Hospital Kegol, and also a few other hospitals. They have initiated cardiac rehabilitation programs recently. So let me show you some statistics. These are the statistics I got from 2017 January to December. Number of coronary angiograms and PCIs done at the state sector, that means NHSL, and private sector Colombo. This is the difference between the numbers. So Center for Diabetic Endocrinology and Metabolism, they have designed this cardiac rehabilitation program at private sector to fill the gap, to provide the service to the population who are unable to attend to a cardiac rehabilitation program in state sector. So our main objectives were share the experiences on implementation of cardiac rehabilitation program, also to evaluate short-term improvements of the program. So we did a retrospective cross-sectional study, a period of 6 months, total 39 patients aged between 30 to 75 years old. The patient recruited criteria was stable ischemic heart disease patients, post-PCI, post-CABG, or patient with heart failure with reduced ejection fraction, and also some people who are having high risk factors for coronary vascular disease. So in the intervention, initial assessments were done by the cardiologist, medical officer, physiotherapist, psychotherapist, and the nutritionist to identify the baseline conditions, risk factors of the patients, and set the treatment goals. So in any cardiac rehabilitation program, the exercise session is the main component. So in the supervised exercise sessions, before the starting of the program, we have individually assessed patients by the physiotherapist and the doctor for the current exercise capacity and the limitations. Then throughout the program, we have taught them the circuit training exercises, endurance and aerobics exercises, strength and flexibility training, and also individual exercise prescription. Following the program, we have evaluated them by 6-minute walk test, resting and exercise response to the heart rate, blood pressure, and also the Borg scale and reserve heart rate. Then the second main component is psychosocial management. By the psychotherapist, individually we assess the patients for their level of depression, anxiety, hostility, distress, and the sexual function, and managed by teaching them coping mechanisms relaxation techniques and stress management, evaluated by questionnaires and the psychotherapy scoring systems. The nutritional counseling was done by the nutritionist to assess clinical conditions, state of nutrition, and guided them on nutrition plans and adherence to diet. The clinical status also, initially we assess with the patient's lipid levels, blood pressure and glycemic levels and the body weight, and manage them by teaching the importance of adherence to diet, exercise and the medication. The medical education, actually this was the very good highlight in our program because most of the lectures were done by the cardiologist and most of the questions were answered by the cardiologist. There we have given special attention to the common unhelpful beliefs that people have, the misconceptions about the cardiac illnesses and that leads to increased disability. We have evaluated the knowledge pre and post questionnaires. Smoking cessation, we have assessed the current smoking status and our goal was to stop them smoking and use of all tobacco products. So in the results, we have had 17.9% participation from females and 82.1% participation from males. And mean age groups were, in our population, mean age was 56.31. And diagnosed diabetic mellitus in our group was 48.8. This is the age distribution in a graph. And when we consider about the highest education level, 56% of our study population has either passed O-level or A-levels, and 23% of them were graduates or some of them were having postgraduate qualifications. Indication to participation, 69% of them were following PCI, 13% of them were having stable coronary artery disease, 7.6% of population were having low ejection fraction, 7.6 again from post-CABG, and 2.6 were having high risk factors for coronary vascular disease. So moving on to results, mean body weight of our study population has decreased to 67.65 from 69.73. Also, the 6-minute walk distance test has improved to 687 meters from 545 meters. All of our population, while doing the exercises, 80% of reserve heart rate they have achieved. And also the LDL, HbA1c and systolic blood pressure. In the beginning of the program, we have set our goals. And at the end of the program, as you can see, most of our patients has improved. Medication adherence and knowledge on basic concepts of coronary vascular disease. There we have given them small questions, 40 questions. These are the correct response rate. At the beginning of the program, there were only 83% of correct responses. When we give the same paper at the end of the program, we got 95% of correct responses. The psychological level were assessed by the psychotherapist, and she has given their pre-programmed psychotherapeutic rates that was mainly varies between 5 to 8 before the program, but at the end of the program, the ratings were improved to 7 to 10. This is self-perception of quality of life. So all of our patients were, when they came to us, they were already had PCI, CABG, or they were on optimal medical management. But still, their self-perception of quality of life, the majority of people were having, they have rated their quality of life as scaling number 5. But at the end of the program, almost all of them have successfully telling that their self-perception of quality of life has improved to 100%. So the conclusion is, following cardiac rehabilitation, there is short-term improvements on behavioral changes, clinical status, health status, and the health-related quality of life. The problems we encountered was the lack of awareness among medical practitioners and the patients, leading to low referral rates. And this is a very time-consuming task, which is non-profitable. Also, lack of self-motivation and self-esteem in patients. Financial problems. Because we got the patients from private sector, most of them have undergone PCI or CABG. By that time, they have spent considerable amounts on their health status. And when we ask them to come for a cardiac rehabilitation program, they hesitate to come. They hesitate to spend more on cardiac rehabilitation programs. And also comparatively low female participant rates. So in summary, non-communicable diseases are in rise, burden of cardiovascular disease are enormous worldwide. The cardiac rehabilitation programs are well supervised and supportive method to achieve the desired goals among patients. So this study will be the first short-term experiences of cardiac rehabilitation in private sector Sri Lanka. And we hope this study will support the future studies to evaluate short-term and long-term effects of cardiac rehabilitation in patients with coronary vascular disease. I would like to acknowledge Dr. Sampath Vithanavasam, consultant cardiologist, for the constant encouragement, support, and the guidance given to me, and Dr. Vajrasena Ratna, senior consultant cardiologist, for the support to initiate the CDM cardiac rehabilitation program and helping us to sustain the program. My cardiac rehabilitation team members and the participants of the cardiac rehabilitation program, and also the CDM management and the staff. Thank you very much for your kind attention.
Thank you, Dr. Jayawardena. As Dr. Zaman said, it's a well-planned study, but the numbers are small. But still we thought we should give this award as an encouragement to a research eye-opener. And I think next time when we will have more research papers and more awards, and we will have Dr. Zaman might have a difficult task when next time I hope we'll send you and we'll trouble you again. And thank you very much, Professor Zaman. And I should thank Dr. Kumudini Ranatunga for supporting us to conduct this award. And every year we will be giving a gold medal and a prize money of ₹100,000, which is quite a lot of money for association to give it to a research award. Thank you very much. And now we have come to the lunch session, and I hope all will be back after lunch, because very interesting sessions and very important sessions are there. Please go away, and there will be prize givings and awards and quizzes. Everything is there at the end of the session. Thank you.